For Global Medical News Network, this is Miriam Tucker reporting from the annual meeting of the American Association of Clinical Endocrinologists, Houston, Texas. We're here with Dr. Moghissi of UCLA. Dr. Moghissi chaired a task force of AACE along with the American Diabetes Association that has developed a new consensus statement on inpatient glycemic control. Dr. Moghissi, what led up to the release of the statement at this time?
Well, glycemic targets in the hospital setting have been questioned over the past year or so because of several studies that suggested that 80-to-1 target for the ICU patients may not be safe, number one, and also may not improve outcome. So AACE decided, because of the emerging evidence, to reconvene its task force and invite the American Diabetes Association in fall of 2008 to look at this question. Do we need to revise the targets? Number one, do these targets improve outcome, these tight targets? Number two, are they safe? And the overwhelming evidence is that perhaps these tight targets are not improving outcome and are associated with much higher risk of hypoglycemia. So the recommendations sort of began to emerge, but we decided to wait till the nice sugar study comes out to consider that data as well. Our recommendation was on the basis of all the studies. It was not a knee-jerk reaction to the nice sugar study, although that's a very important study, multi-center, over 6,000 patients in the ICU, which actually suggested that targets of 80 to 110 not only doesn't help, but is associated with higher risk of mortality in 90 days.
Specifically, what are those targets?
The targets in the ICU that are recommended now is basically to start IV insulin on patients who have glucose of greater than 180 consistently, and to try to reach goal of 140 to 180. We feel that probably the higher benefit may be achieved at the lower end, i.e. 140, although the evidence is not as robust. And for the non-ICU patients, between 100 to 180, majority of the patients 140 to 180, and some patients who have been intensively controlled in the outpatient setting, when they're in the hospital, we may be able to continue those tight targets. But again, these are general recommendations, and we have to try to individualize the targets when we're dealing with the specific patients.
Any other messages that physicians and hospitals should take away from this new statement?
Yes, I think that we need to make sure that the result of the nice sugar study, as well as these new recommendations, does not cause the impression that we feel hyperglycemia in the hospital setting is not important. We know from multiple studies that high glucose is associated with poor clinical outcome. And therefore, we need to try to really find a balance between safety and good control, and use judgment when we're dealing with individual patients.
For Global Medical News Network, this has been Miriam Tucker reporting live from Houston, Texas.